Hello everyone, my name is Andrea. Thank you for watching my presentation. So today we have Mr. MD. He's a 43-year-old male and he's Caucasian. He presents to the clinic with headaches and bilateral lower extremity edema. So his HPI, his symptoms began about 3 months ago, and the headaches occur 3 to 4 times weekly. They're described as dull and throbbing, and they are located on the occipital region, and they last about several hours, and they're minimally relieved by the rest and over-the-counter medications. He also experiences all lower extremity edema. There is some swelling present, and it's particularly after a prolonged standing. He also has self-monitored his blood pressure, which are high readings ranging from the 160s, 170s, over 90s, and has a significant family history with hypertension and cardiovascular disease. His past medical issues are obstructive sleep apnea. Patient does have a CPAP at home. There is no history of diabetes, hypertension, or cardiovascular issues. Surgical-wise, there is no history of surgeries or prior hospitalizations. Family history, there is a strong history of hypertension with the maternal and paternal sides. Social history, patient does have a sedentary lifestyle and poor diet habits, minimal exercise. There is occasional alcohol intake, however, there is no drug use. Medications, patient is taking fish oil, multivitamins, biotin, and also he's allergic to ASA and NSAIDs. So review of systems will be the following. So general is patient does have fatigue and some occasional dizziness. Cardiovascular, patient does have complaints of headaches, lower extremity edema. There is no chest pain, palpitations, or syncope. Respiratory, there is no dyspnea or wheezing present. Neurological, patient has headaches. However, there is no vision changes, weakness, or numbness. Musculoskeletal, patient does have bilateral lower extremity edema. There is no joint pain or stiffness present. Vital signs, patient is obese. His BMI is 44.6. His blood pressure is 176/98. We did retake the blood pressure and it was 180/94 and a heart rate of 97. So physical exam on this patient, general-wise, he is obese, male, and he is fatigued. For HEENT, the patient doesn't have any oropharyngeal lesions. Fundoscopic exam, however, shows hypertensive retinopathy. Cardiovascular, the heart rate and rhythm were normal. There is no murmurs or bruits. However, there was a +2 bilateral swelling edema. Pulmonary, there is lung sounds were clear. In neurological, there were no cranial nerves that were involved. They were all intact and there is no focal deficits. So my differential diagnosis for this patient is going to be hypertensive heart disease, which chronic hypertension can lead to left ventricular hypertrophy, heart failure, and is suggested by persistent hypertension and lower extremity edema. The second differential diagnosis for this patient is chronic kidney disease. Hypertension-induced renal damage requires lab evaluation and proteinuria and renal function testing. Another differential diagnosis for this patient is going to be OSA-associated hypertension. OSA is known secondary cause hypertension, and CPAP adherence must be reassessed. So my final diagnosis for this patient is going to be hypertensive heart disease based on his blood pressure, the obesity, and the strong family history. My diagnostic workup for this patient will be a CBC, a CMP, a lipid panel, a UA, a UACR to assess renal function. And we'll also do a EKG to assess left ventricular hypertrophy, and he'll be started on a 24-hour ambulatory blood pressure monitoring. Medication, so patient will be started on clortidalone, which is a 12.5 milligrams pill, QD pill that he'll be taking. We'll reassess in 2 weeks, and if the blood pressure remains elevated, we will be adding, we will either increase the dose or add amlodipine, 5 milligrams pill QD. Also, referrals we're going to send him to the ophthalmologist for the hypertensive retinopathy and cardiology and nephrology if left ventricular hypertrophy or kidney damage is confirmed. Lifestyle modification. So patient needs to follow a DASH diet, which is normally a sodium intake of about 2,300 milligrams per day. Exercise, he needs to exercise, at least do some brisk walking or low impact workouts. Weight loss, he should lose about 1 to 2 pounds per week through diet and activity. Smoking and alcohol, we need to reinforce that tobacco avoidance and limit alcohol intake is very important. And CPAP compliance, which we're going to reinforce the adherence of the CPAP use in order to improve the blood pressure. And education, patient, we will discuss the risk of uncontrolled hypertension, which leads to heart disease, CKD, or MI. And we'll also emphasize medication adherence for in-home blood pressure monitoring. Our follow-up for this patient is going to be in 2 weeks, just so we can make sure that patient is tolerating all the medications that we're going to be giving him. And we'll be also doing a lab repeat, and we'll check the EKG at the next visit. Thank you everybody for watching my presentation.